Good evening and welcome to Tucker Carlson Tonight. Last night on this show, we played you a clip from a nearly hour-long video produced by two physicians in California, Doctors Dan Erickson and Artin Masihi. Likely many of you had already seen it. That video has had more than 5 million views on YouTube. In their presentation, the two doctors presented a flurry of data pointing to what we are currently learning about this virus and how it spreads. They recited pages of government statistics and then interpreted them in light of their own long clinical experience as doctors. At one point, they noted that the newly adjusted death rate in their state of California, which is much lower than anyone expected it to be, and they asked if government officials there should change their policies based on this new science. Watch.
We've seen 1,227 deaths in the state of California with a possible incidence or prevalence of 4.7 million. That means you have a 0.03 chance of dying from COVID-19 in the state of California. 0.03 chance of dying from COVID in the state of California. Does that necessitate sheltering in place? Does that necessitate shutting down medical systems? Does that necessitate people being out of work?
So whatever your view of the mass quarantines, and maybe you're enthusiastically for them, the questions you just heard are valid questions. In fact, they're critical questions. We should all be asking those questions, including and especially our policymakers. But as Dr. Erickson pointed out later in the video, dissent of any kind is no longer tolerated in this country. Fact-based honesty, which is the soul of science, is under attack, even in hospitals. Dr. Erickson described physicians being pressured to classify illnesses and deaths as related to coronavirus, whether they believe that to be true or not.
We aren't pressured to test for flu, but ER doctors now, my friends that I talk to say, you know, it's interesting, when I'm writing up my death report, I'm being pressured to add COVID. Why is that? Why are we being pressured to add COVID to maybe increase the numbers and make it look a little bit worse than it is? I think so.
So what you just heard, what Dr. Erickson described, is called lying. And lying has no place in science ever. It's scary to think it takes place on a large scale in hospitals. He says it does. Viewers of Erickson's video were shocked and transfixed by this. They forwarded the video to friends who forwarded it on to their friends. And suddenly, millions of people who have spent the last 6 weeks on a diet of Tiger King and internet memes were watching sober-minded medical researchers reading from charts of statistics. It's hard to recall a science video taking off like this one did. Not everyone was impressed by it. Some criticized the doctor's policy conclusions, and of course that's fair. Decent people have different opinions. We're not entirely certain what the perfect response to this pandemic is. Nobody is certain. There's no objective answer at the moment. At best, we can plod along with open minds and good faith. More informed debate is exactly what we need to make wise decisions going forward. Unfortunately for all of us, informed debate is exactly what the authorities don't want. They want unquestioned obedience, so they're cracking down on free expression. Last night, the doctor's video, the one you just saw, was pulled off of YouTube, the largest video hosting site in the world. It wasn't an accident. YouTube admitted doing it. The company cited a violation of, quote, community guidelines, and they did not apologize. Looking back, when all of this is finally over, and it will be, it's likely that we'll see this moment, what YouTube just did, as a turning point in the way we live in this country, a sharp break with 250 years of law and custom. The two doctors' video was produced by a local television channel in California. It was, in effect, a mainstream news story. The video was not pornographic. It didn't violate copyright or incite violence or commit libel. It didn't break any law. The only justification for taking it down was that the two physicians on screen had reached different conclusions from the people currently in charge. It was a form of dissent from orthodoxy. YouTube and its parent company Google have now officially banned dissent. The CEO of YouTube admitted that openly.
But then we also talk about removing information that is problematic. You know, of course, anything that is medically unsubstantiated. So people saying like, take vitamin C, take turmeric, like those all will cure you. Those are the examples of things that would be a violation of our policy. Anything that would go against World Health Organization recommendations would be a violation of our policy. And so remove is another really important part of our policy.
We're removing, quote, anything that would go against World Health Organization recommendations. It'll now be taken off the internet. Consider that for a minute. As a matter just of science, it's ludicrous. Like everyone else involved in global pandemic policy, the WHO has often been wrong in its recommendations. A lot of people have. In mid-January, WHO told us that coronavirus could not spread from person to person. In March, they told us that face masks didn't work. Those were lies, and they were welcome on Google's platforms. Doctors who are actually treating patients with the virus, meanwhile, have just been banned. So no, this is not about science. Censorship never is about science. It's about power.
John Ioannidis, I'm a professor of medicine and of epidemiology and population health at Stanford University. I'm one of the two co-directors of the Meta Research Innovation Center at Stanford, or METRICS. My research is interested in appraising evidence, in trying to understand data, strengths of data and weaknesses of data, and trying to make sure that we have the most useful information to make decisions that matter. Unfortunately, much of the information that we have collected so far, and this is not to blame anyone, it's just something that has arisen very fast and has caught us off guard in a way. It's a new pandemic. Most of that information is not reliable. We have increasing evidence that many of the key features that pertain to what this pandemic is about, how lethal is that virus, how many people it has infected or will infect, what is likely to be the eventual impact, and how effective are the different measures that we're applying. We have major gaps in practically all of those fronts. The WHO indeed released an estimate of a case fatality rate of 3.4%, which at the time of the release earlier in March, it was based on the number of people who had died as the nominator and the number of people who had documented infections as the denominator. And information from settings where we have more complete information about that denominator suggests that the infection fatality rate is much, much lower. We do have some situations currently where we are approximating that number with some fair accuracy. One situation was actually a very early experience in the course of the pandemic. We have a cruise ship, Diamond Princess, where we had an outbreak of SARS-CoV-2. Many people got infected. This is a situation where you have a closed space. People cannot really go anywhere. They live in very close quarters together for the duration of the cruise. So we had an infection rate of close to 20%. 19% of the passengers and crew got infected. And among those who were infected, as of now, 1% has died. 1% is a figure that pertains to a population of mostly elderly people. The mean age of the passengers and crew was 58 years old, and the median, I believe, was close to 65. And we know now that there's a very strong age gradient. People who are older have a higher risk. People who are young have a much lower risk. If you try to adjust for the age difference between the passengers and the crew and the general population of a country like the US, probably an estimate anywhere between 0.05 up to 1% may be more reasonable to consider as opposed to, let's say, 3.4%. Probably an estimate anywhere between 0.05 up to 1% may be more reasonable to consider as opposed to, let's say, 3.4%. I am collaborating with scientists who are leading the Italian response, and I'm trying to get their insights. And this has been a very interesting puzzle that we have been brainstorming on. There are multiple explanations so far that can be proposed on why Italy really became such a disaster. And these include the following. First of all, it's demographics. Italy has the most elderly population in Europe and one of the most elderly populations in the world. The average age of people who die in Italy is 81 years old. And also, most of these people have lots of other underlying diseases. Italy is a country that has a very strong history of smoking. It has very high rates, therefore, of chronic obstructive pulmonary disease. It has very high rates of coronary heart disease, and these are very strong risk factors for having a bad outcome in this infection. And it still remains to be decided how many of these infections are deaths with SARS-CoV-2 versus deaths by SARS-CoV-2. It still remains to be decided how many of these infections are deaths with SARS-CoV-2 versus deaths by SARS-CoV-2.